Good afternoon, everyone. And I'm here presenting on behalf of our large team, whose names you can see listed there, who have worked on the problem of what to do when COVID affects your clinical rotation, just kind of in the middle of the day, really. And so when we think back to kind of being there back in January 2020, and then kind of how this last year has been, that's kind of been our sentiment. We've really seen how medical education has had to evolve at a very rapid pace, and we've had to adapt to situations where we've gone from in-person learning to online learning. And we wanted to share an example from what we were able to do at McMaster for our emergency medicine medical students who are rotating through their core emergency medicine rotations. And so what we did was we broke this down with a couple of different innovative pieces. The one I'm going to focus on today is the CBAL you'll see in the corner. That's case-based asynchronous learning. And so what we did was we harnessed the power of digital communication technologies in the form of Slack and tried to create and mimic some of the encounters that students would have with their staff while on shift. So starting to really introduce some of the key elements, both from a medical content perspective, and then you can also see that it went beyond that in terms of being able to relay some of the communication elements, some of the key elements with patient interactions for patients who may be suffering from certain conditions like dependency or addictions, and also looking at end of life care and how that could affect clerks' rotations in emergency medicine. And so what we did was we took the Slack platform, which we chose largely to be cool and trendy. And I think many of us were watching Silicon Valley at the time. And what's the advantage of this software is it allows for threads, allows for uploading of documents. It can be installed on any type of smartphone or your laptop. And so there's an ability to be connected. And the prompts would be released over 3 days over the course of the week. So Monday, Wednesday, and Friday at 10 a.m., a new series of questions would drop. And the questions would introduce a patient who came into the emergency department, give you some of their basic demographic data, and turn it to the students and say, for example, you have this patient with chest pain, what are the questions you want to ask on history, or what are things you want to ask on look for on physical exam? And the students would asynchronously reply like threads, and then build on the conversation. We would have faculty and resident moderators who would asynchronously log on as well and contribute ideas, discussions, papers, resources. And over the course of the week, you could see that the case unfolds. So this is towards the end of the week. You can see that now that we have the ECG data, we have an ultrasound looking at the lungs, and we have a chest x-ray, and the learners are starting to consolidate that clinical information to really apply it to say, what would I do with this patient? And this takes the case all the way from sort of presentation through initial investigations, through managements and resuscitation, and then takes them towards a disposition. And then usually on the Friday would wrap up with some conversation around that, whether that was the goals of care element and how to have those conversations, breaking bad news, how to help people who are struggling with dependency or addictions issues at their Sentinel presentation to PED. And what we did was we actually did a social networking analysis because we started to find that we were building a virtual community of practice. And you can see here, for those of you who attended the virtual networking session this morning, social network analysis session this morning, you could see that we have faculty members and students really starting to build connections both between each other and other students. And what we found was that the barrier for students to start contacting faculty was very low. And for residents, they also serve as near peers to try and be able to proceed. It brought down the bar for a student to ask questions because of the way that this program and software kind of work. And when we look at active user data, you can see the numbers are quite high through April and June. That's when our entire clerkship shut down for 11 weeks and students were completely on virtual learning. But even subsequent to that, we've maintained high numbers during the periods of time we have learners, and we have high engagement. You can see that there's not much discrepancy between active members and members who are posting. And so the students are remaining active and engaged in this platform. So what were the lessons learned from moving to this virtual community of practice and evolving a case over the course of a week in a virtual format? One of the big things up front was that the faculty investment of time at the beginning was quite substantial. When we first launched it in our first case, faculty were checking their phone over 21 times a day, which I think we can all agree is more commitment than most faculty would want to maintain over a long haul. And I think that was in the initial phase. We were very new and excited. We also had staff who were off from pandemic-related exposures or travel for reasons like that. And so we also wanted to test the system at that. But there is some requirement for your faculty to remain engaged over the course of the week. So it's different than something like a conference where you book out an hour and say, I'm going to log on, I'm going to listen to this talk. This is something where you constantly have to check your phone throughout the week. So it is a little bit of an adjustment for both faculty and residents. Interestingly, residents said that it didn't really affect their life as much, whether that's a millennial piece or the fact that they were so used to using virtual learning technologies already, we weren't able to kind of fully tease that out. Another element is that interaction is key. And that's something that I think students across the board really hunger for, is a chance to connect directly with faculty and residents and building that community. Our model at McMaster is a bit of a distributed campus. We have Hamilton, the hub, and then we also have a hub in Waterloo and in Niagara. And so we have these 3 distinct sites while also having a number of sites scattered across the region. And so what that means is that sometimes students who are in a certain area maybe the 1 or 2 of the students in that whole hospital who are on that rotation. And so using a virtual clerkship allowed us to bring people together and allow interaction. Students could make their own private groups, they could share resources, communicate, work through cases together. And the last thing is that I think we demonstrated that a virtual community of practice and virtual software could be a strong complement and a very feasible part of our clerkship moving forward. Now, 1 year into the pandemic, we continue to use a number of virtual tools. Some of you may have heard about the virtual recess software that Sarah Fui has created that's been integrated to great renown from our students. We're starting to see that in a post-COVID world, we're likely to keep a lot of this virtual technology and then add to it and supplement to it with in-person dedicated specific sessions where we're focusing on skills development or things that we need to be in person for. Because from a distributed campus mindset, these sessions are actually better rated than before, where we used to have a combination of live in-person sessions for some students and virtual transmitted sessions for others. That's all I got to kind of give you a quick primer into here. There's a QR code there, which has our paper, which breaks down some more of our learnings and discoveries and goes through the whole curriculum in a little bit more detail. But I'm happy to have any questions or any comments from the group. Thank you.